Good morning, everyone. It is my great pleasure to introduce my longtime colleague, Dr. Tom Freese, who will be presenting grand rounds today on the substance use treatment workforce and implementing evidence-based practices. Dr. Freese is currently an adjunct professor in the Department of Psychiatry, co-director of the UCLA Integrated Substance Abuse Programs, also known as ISAP, of the Pacific Southwest Addictions Technology Transfer Center funded by SAMHSA. Dr. Freese was previously the ISAP Director of Training for 20 years. He has developed and conducted trainings across the US and internationally on a wide variety of topics, including methamphetamine use and the opioid epidemic, culturally responsive care for LGBTQ individuals, implementing evidence-based treatments, and screening and brief interventions for risky substance use. On a more personal level, I have known and worked with Dr. Freese since I joined UCLA ISAP as faculty in 2008. He quickly integrated me into his training team and provided opportunities to co-present with him in community settings with the aim of translating scientific findings to multidisciplinary audiences who could then use this information to shape their clinical practice. So I am so happy to be here today to welcome Dr. Freese. Thank you.
Thank you very much, Larissa. It's really nice to be here, and thank you for that warm introduction. I can't believe how long we've worked together over the time. I'm really happy to be here today. My pronouns are he and him, and I'd like to take a minute and just acknowledge that UCLA currently sits on land that is the ancestral home of the Chumash, Keys, and Tongva people. The talk I'm going to give today is really one of looking backward and looking forward. We right now find ourselves in the midst of a really devastating workforce shortage in the midst of a devastating health crisis that is addiction. And I thought I would talk a little bit about things that we can do to move that forward. I have no relevant financial conflicts or disclosures. And really, this is the theme of my talk, sort of what is the nature of the current substance use workforce, who is delivering services, and how did we get here, and what do we need in order to address this devastating and deadly health crisis that we're in the middle of. So let's look a little bit at the current situation. Right now, according to SAMHSA, if you look at the issue of substance use, by the way, these are all classified by the federal government as illicit substances. Marijuana is in that category because according to the federal government, it is still a Schedule I drug. I know there's some controversy about that, but that's how it's categorized. You see that about 50 million people are current users of marijuana, meaning they've used in the last month. Doesn't necessarily mean that they have a problem. It just means that they've had some use. By the way, these numbers don't include alcohol, which represents about 150 million Americans being current users of alcohol. That's almost half of the US population. As we get down to other illicit substances, you see that the numbers drop off fairly dramatically, but the next most common being prescription painkillers, and under that, major sedatives. Then we get to the stimulant use. Those are all on the rise at this particular point as well. I'm going to focus on this issue really looking at one variable, and that is overdose deaths. Because right now we're in the midst of a crisis of overdose deaths that is truly alarming. This is the map of the United States, annual overdose deaths by state. Again, 1 in 10 Americans reside in California, so it's not surprising that by number we have the most overdose deaths. This is not a proportional map, but looking at it across the nation, the CDC estimates that in the year ending in April of 2021, there were over 100,000 deaths, and they just updated those numbers. Actually, I saw a few days ago, and in the year ending in October, that number went up by another couple of thousand deaths. That's an increase of about 30% from the previous year. About 3/4 of those deaths are from opioids, but a significant number also involve stimulants, either in isolation or in combination with other opioids. What does that mean? Well, more than 4 times the number of people who died of a drug overdose in the previous year than died by homicide. In fact, it's at 300%. drug overdoses is 300% of what people who died by homicide. Again, about a 30% increase, and drug overdoses killed more people than automobile accidents and suicides combined in the last year. It's a devastating crisis. What's taking people out? It's a combination of things very often. The first larger box is opioids, synthetic opioids being the green bubble, prescription opioids the next one, and heroin the next one. The next set of boxes over are stimulants, methamphetamine and cocaine. It's important to note that these are not exclusive numbers. Many of the people in the stimulant box will also be in the opioid boxes as well because of the overlap of those two substances. The opioid epidemic and overdoses associated with that followed the three waves of the opioid epidemic in general. The first wave in the early 2000s was really about prescription opioids. It was overuse and misuse of those that led to most of the overdose deaths. Around 2010, though, we began to see a spike in heroin as laws changed and people became unable to afford their prescription opioids. They switched to a cheaper alternative, which is heroin. And then along about 2015, we saw a spike in synthetic opioids, primarily fentanyl or fentanyl analogs. And that really is what's resulting in most deaths at this point. But it's really important to note the last 2 years of this slide, 2018 and 2019, stimulants overtook prescription opioids and heroin as a leading cause of death among people who use substances. And it's not just about looking at the nation. Where you are matters. If we look at more urban or metropolitan areas, again, we see high rates of overdose by synthetic drugs, but fairly equal rates of overdose with other substances. As we move out to rural communities, it's really about synthetic opioids and methamphetamine. So the providers that we need in order to address these issues vary based on the location where they're at. And we need a bunch of people in a bunch of different areas. We need people to help us prevent this problem from developing to begin with, people who do primary and secondary prevention. We need harm reduction people who are taking people who are not yet ready or may never be ready to enter the formal treatment system and get them interventions that they're willing to accept in order to reduce the harmful consequences of drugs in their lives, most notably preventing overdoses, as we've seen those terrifying numbers. Then we need us. We need the treatment providers. We need physicians. We need behavioral health providers. We need case managers. We need social workers, all of us who are doing that care. And finally, we need people to help after the fact. Who are the people that are going to help people in long-term recovery? Certainly, they're not going to pay us at our high rates in order to continue to provide active intervention services. So how do we engage them, and who are the providers that are going to do those ongoing recovery services? And where necessary, re-engage harm reduction services, re-engage formal treatment services as well. Well, in order to answer that question, we have to look a little bit about how we got here into this system where we're so split up into so many different segments. So I want to review the history just a little bit of the addiction treatment system and talk about where we came from. So you may or may not agree that I hit all the right milestones along the way. There's some controversy about some of the dates in terms of exactly where it happened, but I think this presents a pretty good picture. We first really started talking about the disease of addiction, specifically alcoholism, in 1784, when it was first defined and made a focus of intervention. Cut to 1864, about 100 years later, the problem had gotten bad enough that they started opening what they call inebriate asylums. And these were open to medically monitor people and give them what medical interventions were available at the time to try to ease their suffering and help them off of these addictive substances. Freud had a really great idea along the way. Freud, who was a big fan of cocaine, decided that it was the perfect treatment for both alcohol and morphine addiction, and was able to recommended it as a medical intervention at that particular time. Along about 1920s, morphine maintenance clinics began to open, and we began doing something analogous to what we now see in the methadone programs, but those were a long way from coming along. About the same time, that whole self-help movement began with the development and publishing of Alcoholics Anonymous. So people began to look at, this is how I gained recovery, and began helping each other in self-help kinds of ways to gain recovery in similar ways. This led to, in 1948, the development of the Minnesota model, which incorporated self-help kind of activities with specifically activities related to Alcoholics Anonymous and the 12 steps. Over time, this was reified primarily because of pressures from the insurance industry and what they would pay for, into what we now know as the 28-day treatment program, which continued to develop and proliferated until the mid-1990s, when evidence began to show that there might be some other more effective ways of intervening with people, and their popularity began to wane. There are still a number of them around though. 1958, Synanon was the first consumer-directed, they called it ex-addict, which we now know is a really pejorative term. So I changed that to consumer-directed therapeutic community. People moved into an environment, lived in the environment, held each other accountable in a variety of really overt and sometimes fairly aggressive ways for their behavior, and trying to move towards sobriety. It wasn't until 1964 that we saw a big advance in medical care of substance use disorders. And that's when methadone, which had been available for pain for a really long time, was formally given the indication for maintenance and the treatment of heroin addiction. In 1972, well, methadone was formally recognized by the FDA in '64, given the indication in 1972 for heroin dependence. It's also in that same year that the FDA separated out methadone treatment from the rest of medical care and made it into its own separate system. So some people said that was great for safety and things like that, but what we ended up with is saying, we'll treat all of your health over here, except for your opioid dependence, which you have to go down the street to the bad part of town, where we're able to license these specialty programs and go in every day to get your care there. And we created this bifurcated, and I would say more stigmatized system for the treatment of drug dependence. 1974, the behavioral groups got together and started licensing and certifying addiction counselors. That wouldn't happen for a while on the medical side. 1982, the federal block grant program separated out from the federal government funding for addiction treatment and gave it to the states. And so now there was a lot more freedom, for good or for bad, in terms of what states were required to or able to do, given the amount of block grant funding that they got and how they decided to use it. 1983, we had our first certification exam for addiction medicine. It happened to have been offered here in California. In 1986, things took a dramatic turn. Nixon actually used the term war on drugs for the first time, but Reagan put teeth in that by changing funding structures and really making it a criminal justice issue. This led to a great increase in incarceration, and in turn, led to a lot of the disparities that we now see, differences in sentencing, et cetera, based on demographics, not based on the disease that we're talking about, which has led to a higher proliferation of people of color in our treatment systems and with this devastating problem than the mainstream Caucasian population. So taking us forward more quickly, in the 1980s to the present, the primary treatment for addiction of all sorts was behavioral treatment. And those treatments were largely completely separated from any medical intervention whatsoever. When I would go around and I would ask people, when's the last time your client had a physical? They would look at me like I had two heads. Like that was such a bizarre question from me, that we would be caring for their medical needs along with their behavioral health needs. 1980 to 2000, we began to see these increases in drug epidemics. Starting in the West and rolling east, we had the stimulant epidemic. Starting in the East and rolling west, we had the opioid epidemic. They crashed really hard in the Midwest, where things are still raging, but then they kind of rolled back. Stimulants have never left the West. and opioids have never left the East, but we see a great deal more merging of those epidemics all across the country. One big change, again, another medical change from 1964 to 2000 was the Drug Addiction Treatment Act of 2000. And this was the legislation that allowed for medicines that met certain scheduling requirements to be prescribed in regular physician's office rather than in the specialty clinics, the methadone clinics. And that led for the later, 2 years later, rollout of buprenorphine, which now has been incorporated in many medical settings. And as we've already talked about, these overdose deaths have continued throughout the 2000s. So we have a system where the substance use disorders treatment is largely provided by paraprofessional staff in specific substance use disorder clinics. There's increasing medical involvement, which is really a good thing, primarily around the opioid epidemic. I think it's led to some merging of systems that have been really, really positive. But unfortunately, across all disciplines, there's a lack of systemic training that's available at almost every level, unless you're going into a specialty SUD service, in what is a substance use disorder and how do we care for it. In my own training as a psychologist, I got 1 2-hour lecture on the DSM-4 at the time. They said, that's all you need to know about addiction because it's not ours to treat. And that idea still, I think, predominates in much of our treatment systems across the country. This is a workforce study that was chartered by SAMHSA, and it looked at the number of treatment providers we needed across a wide variety of categories in order to meet the treatment needs for individuals with substance use disorder. I think it's particularly notable that psychiatrists and child and adolescent psychiatrists are only indicated, the treatment need is, or the provider need is only indicated for those with serious mental illness. They're not indicated at all for substance use disorders. Likewise, people who specialize in addiction medicine or in addiction psychiatry are only noted on the addiction side. And of course, they would never treat someone with a serious mental illness along the way. It's preposterous. So there's problems in these data to begin with. But if you look at, this is the number of people that we need across the board. What that translates to is we currently have about 700,000 people providing services for substance use disorders across the country. And the need right now, according to this report from SAMHSA, is 4.5 million providers. Is it any wonder that people have trouble getting access to care when we have such a workforce shortage? And the COVID epidemic, I think, will make this problem even worse with what we know is the exodus from the workforce that many people have engaged in. The average counselor, by the way, about 60% are women. About their average age is about 38 years old, and they're primarily Caucasian. I actually wasn't able to find recent statistics on the average substance use client, so I decided not to show them. But all of the data that I was able to gather shows that the average substance use disorder client is 25 years old, a person of color, and male. So we have white women treating men of color with a vast age differential in our treatment system. So again, another way that we have a shortage. Well, what's the solution? The solution is we need more people able to do evidence-based practices for the treatment of substance use disorders across the spectrum of providers, and encouraging people to work toward the edge of their certification or licensure in the implementation of this while we try to grow the workforce. This is a list from NIDA, the National Institute on Drug Abuse, of currently recognized evidence-based behavioral practices or behavioral treatments for the treatment of substance use disorder. All of them should look fairly familiar to you, but when you go around and you ask medical staff or you ask even behavioral staff, they may know 1 or 2 of these, but they don't necessarily know all of them, at least how to implement them with fidelity. When Larissa introduced me, she mentioned the Pacific Southwest Addiction Technology Transfer Center. It's a SAMHSA-funded grant that set up regional training centers that line up with the Health and Human Services regions. So I'm the director of the Pacific Southwest, which is HHS Region 9. We got together as a group and using Everett Rogers' initial diffusion of innovation model began to look at how do we spread information about evidence-based practices to people who need it. And we came up with this technology transfer model. The model really starts with the development of an idea. That's where the research comes in. It moves through translation of that research into wide-scale dissemination. People need to know about it in order to know whether it's interesting or not. Then specific adoption to particular locations. What do we need to do in order to make sure it works for a group of Pacific Islanders, a group of Black people in Los Angeles, or Native people in Northern California, for instance? Once we've done that kind of adoption and people are interested in it, then we can work really specifically to move toward implementation and making it routine practice within a variety of systems. This is a beast of a job, people, and is really challenging to cover all of these issues. I have the fortune of having developed over the last 20 years a training program with my colleague, who's now the director of training, Beth Rutkowski, of really trying to find ways of addressing all of these issues. And I want to share a little bit of the ways that we're doing that now so that we can all work together on similar kinds of models. So in the dissemination arm, what we're really looking at is exposing people to information, increasing awareness, and trying to help them see the utility of intervening with these practices. So things like conferences, it's a picture of a conference that we ran for a number of years, a variety of written materials and manuals, fact sheets, webinars, anything that we can do to get information out about it. By the way, purely self-serving. If you need free continuing medical education or other continuing education, that QR code is invaluable to you. Most of what we have CMEs for are opioid related at this particular point, including what is it, how do they work, how do we treat it, how do you provide medicines for it, and how do you prevent overdose. All of our continuing education across all disciplines is free of charge. Please take advantage of that. Enough of that commercial. On the adoption side, this is where people are trying it out. Do I want to do this or not? So what we do is we have a series of trainings that we've developed that are really about specific skills. We engage people in role playing, help them develop skills, demonstrate their skills in real time, and give them live coaching in situation so that they can practice those skills and develop competency in them. And then we do ongoing skill assessment and feedback for them in order to make sure that they continue to develop those skills and move toward fidelity. Implementation, this is where it often stops. Many agencies will say, I have the resource for you to come in and do a training that's not nearly long enough in order to adequately teach these skills. And then we want you to go away and we're going to do this with fidelity forever. That works 0% of the time. What we really need is an ongoing programming like we do in medical education of coaching, helping them infuse technology, understand the systems, refine skills, get feedback, on and on and on, so that they can figure out how to implement these skills with fidelity. And all of this within the traditional substance use disorder treatment system requires a great deal of change management, because it really means doing things in a different way, setting up systems in a different way so that you can actually do these interventions in the way that they're supposed to be done. On the medical side, we have a growing number of medicines that have been approved for a variety of substance use disorders. Opioids, alcohol, and nicotine specifically. You'll notice that stimulants are not on this list. I don't know how many compounds have been tried to find a medicine that will actually meet the requirements for FDA approval for this indication, and we haven't found one yet. In each of those categories, there are a number of medicines that are being used off-label at this point because they've shown some efficacy in small trials, but they either are too small a trial or they haven't been able to be replicated in order to gain FDA approval at this point. But there is information out there about some off-label use for each of these categories as well as for stimulants. Translation, substance use disorder treatment is complicated, it's multifaceted, and requires many, many different providers in order to be involved. Again, this is from the National Institute on Drug Abuse, and each of those squares in the middle represent some piece of the substance use disorder treatment program that I've talked about in the last few minutes in terms of our rollout of evidence-based practices. And around those are all of the supportive services that people need in order to effectively provide care and help someone enter long-term recovery. So in order to provide adequate care, we need to ensure equitable access to services. We need a diverse and interdisciplinary workforce that actually represents the clients that are coming into our program. There's a study, and I wasn't able to find it, so I'm not going to quote it exactly, but the study indicated that if you simply match based on demographic characteristics like race and ethnicity, the person overall will do better. I'll find that and I'll include it in my references as we go along. But I think it's not surprising that if you can relate to the person sitting across from you, you're likely to engage in treatment more, you're likely to be in treatment longer, and therefore likely to have better outcomes. We need a lot more research and knowledge development, but we also need to train not just on what are the evidence-based practices, but how do we infuse these into practice in the most effective way? So really training related research, not just service related research. And we need to ensure that everyone has the sufficient skills that they need. ISAP has about a, I don't know, 40-something year history. Isn't that a great animation? I love that. It took me years to figure that out, and now I forget it's in there. ISAP has about a 40-year history of providing services around all of these issues. We have a large number of programs, including long-term cohort studies, statewide evaluation projects, substance use disorder treatment effectiveness, addiction health services research, cross-system studies that factor in multiple people. And in the center of that, we in training try to take all of that information and infuse it into useful nuggets that a provider in the field, whether they're early on in their training or they've been in the field for decades, can use that information to improve the quality of the services that they provide. Right now, ISAP has about 69 staff in total with 15 independently funded PIs and about 38 separate projects, be they research, evaluation, or training, with 12 of those being NIH-related funding. This is the team, my little training group. We've actually grown. There's another 6 people who will be joining our group. We work really hard in order to be able to do this, but we really need partners. We provide over 300 trainings a year across all the domains of the technology transfer model, and covering a variety of different populations, not just the traditional substance use disorder treatment setting, but also mental health, correctional institutions, health centers of a variety of sorts, and specialty health care, most notably HIV and child and pediatric care. We do a lot of training as well in community outreach and service settings. So our trainings often have everything from someone who's about 15 minutes from their own use history who wants to help people to physicians in the field who are practicing. And we're working to train these skills with all of those people at the same time. One of the things that I don't think we understand enough and that we do a lot of, in spite of that lack of understanding, is cultural adaptation. We do a lot of work on the Pacific Islands in the Western Pacific. We do a lot of work with tribal communities here in the US, and we've done a lot of work with the LGBTQ communities across the country. And with each of these, what we've recognized is that the interventions that were developed primarily by white researchers with white populations in sort of affluent settings don't necessarily work in a lot of these settings. The language is wrong, the images are wrong, the metaphor is wrong, and we need to adjust all of that if we're going to help people use it at the local level. And most notably, we need to spend the time to understand local custom and local social mores so that we're not trying to impose some Western developed idea onto an indigenous culture, but really infuse what we know works into that culture and their cultural practices. So some of the challenges that we face on an ongoing basis that I'm hoping we can work together to address are this abstinence versus harm reduction debate. If you require, we know from research that if someone becomes totally abstinent, they're likely to do better in long-term recovery than if they continue to use anything, because chemical coping tends to lead to chemical coping. That's not true for everybody, and it's not my business. If someone is not willing to go there and not willing to say, I'm not willing to stop using stimulants for the rest of my life, the traditional response to that is go out and experiment some more and come back when you're ready for treatment. In other words, go out and die, but if you don't, and you're still alive and you want to change, come back and we'll help you. That's a real problem. looking at harm reduction strategies as a way of gaining trust with people and meeting them where they are, and gradually, as they're interested, moving them more and more into the formal treatment system, if they ever want to do that, is a way of connecting with people and helping reduce the overall impact. There are a large number of these. A lot of the substance use disorder treatment workforce is really uncomfortable with incorporation of medicines into treatment care. They think, I got abstinent without any medicines. Other people should be able to do so as well. Even in the big book, it says there are many paths to recovery, and we need to help each person find that path to recovery. And for many people, and the science would say the frontline research for many drugs, the frontline intervention for many drugs is really medicine first, other services later. We save lives, people do better in the long term. Managing that balance and helping people understand both sides of that argument becomes really important. Training different staff with different levels of experience at the same time, overcoming resistance to just doing skill practice. I'm someone who, if I'm in a training as a participant and they say it's time to do role plays, I suddenly have to go to the bathroom or take a phone call because I hate those things. So we work really hard to develop our trainings in such a way that I would sit in a room and do that skill practice, and to make it as not threatening as possible, but to have people take the risk to actually practice and develop the skills. Virtual versus in-person training. This is a weird environment. I'm speaking to over 100 people, and there are about 8 in the room today. How do we manage that, and how do we make sure that we engage people in an effective way when we're looking at these multiple environments where we're disconnected from each other in a variety of ways? And finally, there are all the issues around utilizing a multidisciplinary team. We need to find ways of recognizing the expertise of each role. I'll tell you, line staff addiction counselors are terrified to talk to a patient's physician. They think they're not going to be able to get respect, or they're not going to be able to communicate with the physician in a way that conveys their understanding in a language that's appropriate in that interaction. Likewise, those of us at higher levels of the profession often don't think about recovery workers out in the community doing this kind of work. And yet for those patients that we're struggling with, they may be the most important people for our services to become more effective. How do we bridge those gaps and understand the expertise of each person who's involved in the system? We need to clarify those communication levels, those communication issues, and look at all of the different ways that we talk about these issues. I try really hard, and I don't think I've used a whole lot of jargon during today's talk, because jargon is barriers for somebody. It works really well in some contexts, and it doesn't really well in other contexts. And I think simply taking that step of de-jargonizing and destigmatizing our language can go a long way to facilitating communication. And finally, there's the whole issue. If you're doing services in a medical setting, there just isn't enough space and there isn't enough time. When our service categories are couched in 15-minute intervals, having a behavioral intervention in that space is not feasible very often if it's more than just a few minutes. Where does that happen? How does it happen? And how do you connect the systems and the patient flow? So there's a lot of efforts that are going on in this regard to bring all of these services together. I told you ISAP has a 40-year history in doing that. And recently, the new Division of Addiction Psychiatry was announced. And it's my pleasure to give back to Larissa, who's the director of the new division. And I'm thrilled to be working with you on this new endeavor. It's going to bring together it's still under development, but it will bring together a large number of people who are specializing in addiction, clinical research, evaluation, and training and technical assistance services under a single roof, broadening our ability to collaborate with each other, but also broadening our impact as we reach out. Likewise, Larissa has plans to sort of connect with key researchers across the university and elsewhere to make sure we form those allied relationships that connect our work to people who are doing similar work in other domains that's essential for our understanding. And I'm really happy to say out loud for the first time that Larissa has asked me to serve as the Director of Training and Dissemination for the new Division of Addiction Psychiatry. And so it'll give me an opportunity not only to continue the work that we've been doing through our work at UCLA ISAP, but also potentially have more interactions with fellows and other pre-service kinds of trainees who we can work together to continue to grow and make sure that we infuse this really critical information, this life-saving information into the care that people give as they move out into the community. It's a long ride, starting in the mid 1700s to today, but the world is different now than it was not so many years ago. People are dying in droves of this disorder. The pandemic had something to do with it, but it is not the underlying explanation. The workforce shortage has a lot to do with it, and lack of information and lack of access to care has a lot to do with it. I hope we can all work together to address that. And with that, I'll pause and ask Larissa to help me out with any questions that have come in, and let's see what else we have to talk about. If anyone in the room has questions, I'm happy to address those as well.
Great. Thank you so much for such a wonderful and informative talk, Dr. Freese, and such an important topic. I'm happy to take questions. I can actually start with one if it's
Great.
okay. In all of your years of experience now with training and dissemination efforts, one thing we always hear about is, and you mentioned this in your talk, the myths around medication treatment for opioid use disorder, the stigma around that, the idea that, oh, you're substituting one drug for another. I would imagine some of the participants in trainings, seminars are those with an open mind who want to learn, but how do we get through to those who are not necessarily participating? And my question is, have you seen a change? Is there a cultural shift, more acceptance of medication treatment, evidence-based treatments in general? And if not, how do we start to break through in that area?
Phenomenal question. Thank you very much. Yeah, we see it on an ongoing basis. And this issue, this schism that exists between those who have grown to accept medicines for addiction treatment and those who continue to push back still exists. We do a lot of anti-stigma kind of work in trying to convey the truth of science related to these potentially deadly disorders. And almost every medical condition that we have has medicines that are associated with it. Some of them also have really important behavioral components. Diabetes, hypertension are two examples where many people can do well with just behavioral interventions, but some people need medicines for a short time or for the rest of their lives in order to restore their body to the condition of health in that particular way. Likewise, addiction changes the way our brain functions. And if we can simply give people the message that your brain isn't the same brain it was before, or maybe it was never the same brain that other people have, and it needs medicine in order to occupy those spaces so that it can function more normally. It's very much analogous to treating diabetes, much less analogous to treating a purely voluntary behavioral condition, which we know that it's not. And I think the more we can work together to get those messages out and say, this is a medical condition, it is a brain disease, we can point to the area of the brain which is diseased, which is no longer functioning the same, and we can make an impact in that area.
Right. Yes, thank you. And certainly the role of clinical champions, people who can influence at their local site, at their treatment facility, that can be a wonderful influence. Also reimbursement structures, and we're not paying for this service unless you're offering the following gold standard treatments. But one issue I'm still hearing about is private pay addiction specialty treatment facilities, where they may not be as dependent on insurance reimbursements.
Yep.
This is the hardest area to break into, to change.
Absolutely, in every way,
treatment.
It's the hardest to break into because they're also unregulated by the state. At least here in California, they don't have to be licensed by the state of California in order to be able to provide those services. So they really can do anything that they want. We've tried to make inroads. There's a conference every year that's held out in Palm Springs that's specifically for that industry. And we inserted ourselves in there, and we're in their display room where they're giving away lots of really expensive things, and we're giving away little candies because it's all we can afford, but trying to get them information. And then we run a track in that conference that's on evidence-based treatments, almost always focusing on sort of this connection between the medical systems and the behavioral health systems. So we have to find our inroads, and we have to be consistent in our messaging. And I think we can, we've seen evidence, it's changing.
Great, thank you. Other questions, Dr. Grella?
So the question that I get asked a lot, and I'm sure you do too, and what I want to know is, how would you answer this?
Okay.
Which is, somebody approaches you and says, I'm desperate, my son, daughter, spouse, whatever, has a serious problem with addiction. How do I find a program? What do I look for? What are the things that I should ask the program to know that they are doing the evidence-based treatment that you are training people on?
Yep.
What are the signs of a good program?
Awesome. So it's a great question and sort of an impossible question, because the real answer is, as we demonstrated, there aren't always services available everywhere where someone needs them. So some assessment about how flexible are you in terms of finding that program becomes really important. But what do I look for in that program? First of all, I always recommend going to a state licensed or certified program, depending on the requirements of the state, simply because across the nation, the federal block grant requires implementation of evidence-based practices, at least one, as a component of their overall care. And then specifically asking questions about what does the treatment look like when someone gets there. Finding out if they have good medical coverage, either directly in the program or by association, is really critical for the treatment of the substance use disorder in many cases, but for the person's overall well-being. And then how do they do their behavioral treatment? And I always send people the NIDA Blue Book, which is a review of evidence-based treatment as we understand it based on science. So that list of evidence-based practices that I showed earlier came from the NIDA Blue Book, as did that other circular image. And it has a list of, these are the 10 things that really constitute a program that is moving toward evidence-based services. They don't have to have all of them, but the more of those that they have, the more likely you are to be in a program that can be really helpful. It's an answer that we could spend, it's a question that we could spend probably 2 days answering, but with that resource, I think that's the general message that I would give people. You want to add anything to that?
I'll add, don't just do a Google search and call the first facility that pops at the top. There's often, that wouldn't be an indicator of quality. You really do have to do the research and ask these questions about embedded psychiatry services, treatment of co-occurring disorders. What does the actual program look like? Are they getting cognitive behavioral therapy or other evidence-based therapies?
I would also say that the SAMHSA treatment locator, which is a great place to start. You go online, you look for, find treatment, there's a treatment locator there. Those are self-determined, program determined check boxes that people take off. So they say, I have, cognitive behavioral therapy, I have LGBT related services, I have gender specific services, I have trauma informed services. It may be that they checked a box and they have none of that, or it might be that they have all of those. So if one of those categories is something that's specifically appropriate, calling the program and saying, do you actually have services for LGBTQ people, and what do those look like? Describe your programming for me, or gender, or any of those other issues that we've talked about, so that you know that it's not just a checkbox, but you're actually going to get the service that you're expecting.
Great, thank you. I'll offer one from the Q&A box. Are there any treatment models available that include group therapy concurrent with medication treatment?
Almost all of the medicines that are approved for the treatment of addiction were evaluated on a platform of psychosocial services. What that platform was is very variable, but generally included some element of cognitive behavioral therapy. The recommendation is that these medicines always be given where the patient's willing to accept them, always be given in combination with good behavioral therapy, because the medicine will take away a lot of the symptoms, help the person function more normally. But if the rest of their life has been devastated by issues related to addiction, they may not know how to put their life back together. And behavioral treatment will help with that. I also know, however, there are people who come in and say, I just need a medicine because I can't stand the withdrawal and I want to go to work, and leave me alone. And we should be giving those people treatment as well. So really important that we have access to those services, not essential that every person take those services.
Great. Any other questions from our audience here? If not, I can move on to other Q&A box questions. What about teletreatment programs, either during COVID or previously, for access to people in remote areas or transportation impediments? How effective are they?
It's a good question, and one that we're just beginning to understand, frankly. The funding systems that were set up really prevented, the public funded systems really prevented telemedicine up until the pandemic shutdown. Even my own doctor now, I have remote visits with him for medical follow-ups, and I'm like, why have we never done this before? Because it just makes sense. But federal funding doesn't always have to make sense, but they did catch up here. And so we're really trying to understand the impact of those. But what we know is we get greater access to people. People continue to come back for care, and there are right ways of doing it. And there are some educational programs that are available and some materials out there that can help people figure out, how do you implement a telemedicine program in the most effective way? Beyond the topic of today's talk, but I would say that it is the horizon. And I don't think we'll ever be able to go back to a system that doesn't in some way include telemedicine and teleconnection, particularly for those in rural communities. But living here in Los Angeles, I don't want to drive from Glendale to Burbank, which is really only about 6 miles, but can take me a half hour to 45 minutes, depending on the time of day it's there. So there are lots of barriers, and I think we can use that to overcome them.
Yeah, I agree. Here's another question. Have you witnessed occupational therapy, OT, being incorporated into SUD treatment teams? What is the impact that you feel OT can have on treatment for SUDs?
Yeah, I personally, no, I haven't. I know of programs that have them, but I don't know a lot about them. That being said, that circle of all of those ancillary services that are essential for helping a person enter long-term recovery, it includes vocational training, occupational assistance. It includes connecting with childcare and lots of other things that will help the person live a happy, healthy life. So I would say for an individual with a substance use disorder, we need to treat that person. We need to identify all of the areas of need they've had. I never had a job and I've been high on every job that I've had. That's a problem for someone looking for a job right now. They need good occupational and vocational training in order to be able to move into the workforce in the way that they want to and in a way that's effective for them. So do I have research? No. Is it a good idea? Do it. Absolutely.
Okay. Is there any data on the efficacy of non-certified, non-evidence-based services such as pricey rehab centers?
Such as pricey rehab centers? Wow. I think that frankly, there is a program in Malibu that's cured addiction. They put it in a book, so we know it's true. I think the quality varies. There are privately funded self-pay programs that I know are doing really good work. But the criteria are still the same. There are other interventions out there that will become evidence-based practices, particularly culturally derived practices. And I really want us to find those and continue to do the work to figure out what can we add to this arsenal of evidence-based practices. But what I know is if I had a loved one who had an addiction-related issue and I wanted to get them care, I would look to that list that I showed of evidence-based practices, and I would make sure they're getting as many of those as I can get them access to, regardless of whether it's a purely self-help program, a private self-pay program, or a publicly funded program, because that gives us the best likelihood of success. That will save lives.
Thank you. Can you specify some of the medications even off-label in the pipeline for stimulant use disorder? Oh.
No, but I'm going to ask my colleague, who I adore, Dr. Larissa Mooney, who is an addiction psychiatrist and therefore more qualified than I am to address that issue.
Okay. I can give.
Sorry to put you on the spot.
No problem. Some medications with off-label use for stimulant use disorder, meaning these are not robust, they have signals of efficacy. Bupropion for methamphetamine use disorder, also recent publication in combination with naltrexone. Topiramate, some evidence for cocaine, methamphetamine, modafinil for cocaine, mirtazapine for methamphetamine use disorder, 2 RCTs. And some evidence for prescription stimulants, methylphenidate for methamphetamine use disorder, mixed amphetamine salts for cocaine use disorder. Of course, with the caveat that those are also not without risk, and you really have to do a risk-benefit analysis because they, for some individuals, can lead to misuse or use disorder.
And as I understand that research in particular, it's really for those that kind of the highest levels of use that seems to be most effective for, if it's effective at all.
For the prescription stimulants, yes, exactly. For other medications, it's sometimes the lower level users that have done had better outcomes in trials, like bupropion, non-daily users of methamphetamine.
Interestingly, the bupropion trial that we were involved in, they were replicating it, and they actually closed the study after several years because there weren't enough low dose users to be able to fill the cells. And so while it might be a medicine that is appropriate for people who are using low, and if someone needed a mood stabilizer or antidepressant, why not try Wellbutrin if they're also using methamphetamine? Because that might work, again, off label, but I don't think we can consider it a frontline treatment for most people, because most people are using at higher levels than what the research was done on.
Okay, moving along.
I know a lot. I just wanted to turn it over to the expert before I added my 2 cents.
Let me just digest this one. Do you have information on effectiveness with the French who have used methadone for years to see the long-term effectiveness for lack of recidivism? I'm going to speculate that this is in relation to opioid use disorder.
Yeah, I'm not sure of the specific French studies that the question is talking about, but there is a very lengthy history of the efficacy of methadone for ongoing care of someone with a substance use disorder. I think in the US, one of the biggest problems is this bifurcation of the system, so that you have to go in every day. It's very, very disruptive to people's lives in order to receive opioid treatment through a narcotic treatment program. That being said, if we had a medicine that works as well as this medicine, someone would have won the Nobel Prize over it if it wasn't for addiction. It works in every domain of life. People do better in work. People don't get HIV. People don't relapse to substances. People live happier, healthier, and productive lives. They have higher quality of life indices. Variable after variable after variable after variable, methadone improves all of those. And so I think it cannot be understated the importance of this medicine in the treatment system. And buprenorphine, while a great medicine, as I understand the pharmacokinetics of it, someone's got a very high tolerance, it may not be the best medicine for them, because the ceiling effect in buprenorphine may not be able to hold them without getting their overall level of tolerance down in some way. So methadone will continue, I think, to maintain a very important role in our overall treatment system. I hope that somewhat addresses the question.
Do you have much experience in supported employment and supportive education as an intervention for SUDs, SEE? Simply put, SEE services involves the use of a job coach or an education coach.
Yes, yes. That's the whole answer. Again, anything that we can do to help people become employed. By the way, it's really hard. A lot of people, if you have any kind of criminal history, you can't be employed in a variety of different settings. Figuring out how to get a job, how to spin your own history so that you're not disqualifying yourself from jobs without lying about that history, and figuring out how to develop the skills associated with the job category that you want to be involved in, all really, really critical. I think one of the biggest sources of relapse is feeling like a failure. And I think our value that we put on work and the workforce is one of the ways that we can easily, quote unquote, feel successful if we move forward in that. And if we're not, it's one of the quickest ways to failure as well. So I would highly support any kind of supported employment or other job-related programs. And if you're hiring, hire people with histories of a variety of sort. It will expand your workforce, and you'll get some of the most amazing creative people that you've ever encountered. Think about the creativity that it takes to have as your job your addiction, and all of the things you have to do to find the money, to find the resource, to use it, to hide it from people. That is a tremendous amount of human capital that we can, if we can parlay it into positive ways, becomes a majorly successful employee in the right situation.
Okay. Very important question. As a follow-up to the question about medications being evaluated in combination with a platform of psychosocial services, my understanding is that efficacy of these medications have only been proven in combination with psychosocial treatments. Are there studies showing that medicines alone can be effective? If not, can you comment on the utility of having such studies without the psychosocial platforms? Do you think if such studies showed efficacy, the medical community would be more willing to use these medicines? And I will say, before turning it over to Dr. Freese, that depending on the medication study, the platform is sometimes just brief medical management with a physician, very, 10 to 15 minutes reviewing adverse effects, return to substance use, but happy to tag team more or.
Yeah, I would love for you to tag team more. I think that the answer is there have been controlled trials looking at people beyond what Larissa is talking about. We have a medicine with this minimal psychosocial support underneath it. Those have shown positive efficacy as well. Many of the other medicines are layered on top of at least, maybe not as robust as you get in a standard behavioral care, but a significant amount of cognitive behavioral therapy. In both cases, what we know is that medicines bring people into care and hold people into care and lead to more positive outcome, fewer overdose deaths, fewer use episodes, overall improved quality of life, less use when people do return to use, et cetera, et cetera. And in all of those cases, the likely outcome, if we said, you won't go to psychosocial care, we're going to take your medicine away, is death. So we don't really have a choice here. What we know is the medicines work, and the medicines work independently. We know that from the research, and we know it from vast amounts of clinical experience. And I'll let Larissa speak to that if she wants to. But we also know that kicking people out of care for any reason likely results in death, depending on the category of drug that they're using, and certainly a lot of morbidity and mortality from other causes than overdose if they're using other substances that may not immediately kill them. And so engagement. And if I could stand here for another year and say only that word, that's the primary message that I would send. You want to add anything?
Yeah, I'll just add, and then we'll need to wrap up today. Time went fast. That studies of buprenorphine for opioid use disorder, primary care settings where they had basic med management platform and compared that arm versus buprenorphine with a more robust behavioral treatment like cognitive behavioral therapy, did not show improved outcomes from addition of these robust treatments. So it really depends on the medication. And in the case of buprenorphine for opioid use disorder, we know that we shouldn't withhold the medication, as Tom mentioned, because they are not able to or interested in or willing to accept additional psychosocial treatment. And the medication itself is so robust that they didn't always find a difference in effects. That's not true for all medications. But in the case of opioid use disorder and buprenorphine, we've seen this. So I think that's an important message.
As a therapist, that study really hurts my feelings because I really like to feel important. But truly, the most important intervention is the one that works the best. And you're right, we didn't see any differences in that study. And likewise, contingency management, giving people positive incentives for not using drugs, most cases, a negative urine drug test, works better than a lot of what I do, right? And so what we want to do is we want to engage the person and engage them in a multifactorial way at the level that they're willing to be engaged and keep them in treatment, engage. And with that, we should close.
We'll have to wrap up, but we'll chat with you after, Dr. Grella. Okay. Thanks, everybody.
Thank you.
And Dr. Freese.